Hey everyone, welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today, our guest is Dr. Todd Edelson, and he's going to talk about the importance of communication in everyday practice. Todd is a physical therapist with 40 years of experience, and he earned his McKenzie Institute certificate in 1991, diploma in 1994, and joined the McKenzie faculty in 1999. Todd is also the owner of Montclair Physical Therapy. I hope you enjoy the show. PT Pro Talk podcast is only possible with the support of the forward-looking and innovative company Rangemaster, the most trusted brand for shoulder therapy tools. Available now on Amazon. Hi, Todd.
Hi, Mariana.
Welcome to PT Pro Talk. How are you today?
I'm well. How are you? Thanks for having me.
I'm doing well. So let's just get started and tell us a little bit about yourself, your career, and how did you get where you are right now?
Okay. So I just celebrated 40 years in practice in December.
Oh, wow. Congratulations.
Well, thanks.
That's a lot of years of experience.
Well, it seems like 40 minutes to me until I look in the mirror and I see the gray. And then I realize it probably is 40 years.
It's just experience.
Yeah. So I guess back at the beginning, I have an undergraduate degree in microbiology. And then I went to the University of Pennsylvania and I got a certificate in physical therapy in 1981, ergo the 40 years. But I also had a keen interest in the hard sciences. So I went back for a graduate degree in immunology and I finished that in 1985 at Montclair State and the University of Medicine and Dentistry. That's where I did my research. Spent about a year in an orthopedic research lab doing immunology. So that was very interesting. And then when I started working in physical therapy, I would say the first year or so, I was very frustrated because I was not sure whether people were getting better because of what I was doing or in spite of what I was doing. So I took a lot of continuing education courses, and in 1981 and 82, there was not a lot of evidence-based practice. And so I was not quite sure whether this was something I could continue doing. So by the end of my first year, I decided maybe I'll go back to medical school. But I thought, well, I've got a profession here. Let me try one more course. And I took a McKenzie course.
Oh, wow.
And this was in 1982. So
that was quick.
Yep. So this was 39 years ago.
And wow.
It just resonated with me. It made sense. That there were 6 or 7 patients on the course. And if you're going to take yourself seriously as a system, you better leave yourself open to all comers. And just Robin's approach, it made sense. It was science-based, and my background was in the hard sciences. So he used the scientific approach, gathered all the information from the person who knew more about the problem than anybody, made a hypothesis, and then tested it with one intervention. And then I thought to myself, this is why I went to physical therapy school.
I was glad that was so quick. You didn't give up. It was just 1 year after you graduated.
No. Well, yeah, I was very happy to have seen Robin in my first year out. So I feel very fortunate that way. And then I worked for 13 years. I took all the courses. I took them again. I started to sponsor the courses. So I got to see all the faculty come through. And in 1994, I decided I wanted to learn how to do this from the best people in the world. So packed up my family, moved to New Zealand, because in 1994, that was the only game in town. And so I came back from New Zealand in 1994 with my diploma. And in 1999, I joined the U.S. faculty. So that's my story. I actually went on to do a DPT at Mass General Hospital's Institute of Health Professions in 2004. And then I joined the faculty in 1999 and became a diploma tutor in 2003. So that's where I am now. And, I find it hard to believe that I've been doing that going on 22 years now.
That's crazy. And I'm just curious to ask you about your experience in New Zealand. So you learned from Robin McKenzie.
Well, so Robin was not teaching the diploma course at the time. There was a diploma tutor,
Mm-hmm.
and but it was really quite a wonderful experience. And we can talk about this later, because I know you have some questions about things that I talk about with referral sources and communications. So we can talk about that a little bit later.
Yes, absolutely. So let's jump to our topic. What is the importance of communication in everyday practice?
Well, so I actually think that this is the essence of what we do. So if we aren't communicating with the person who's sitting in front of us, I think we start to make some assumptions about what we think the problem is. And this very frequently leads us down a really bad road. I had been working, when I got back from New Zealand, I'd been working for about 13 years as a physical therapist. And when I came back, the physicians that I worked with, they asked me, so, 14,000 miles you travel when we have the best medicine right here in the United States. Well, why did you have to go to New Zealand? And to that, I answered, well, we maybe not the best conservative musculoskeletal medicine. And so that, they kind of rolled their eyes and they said, well, so what did you learn? And what I had told them was, well, what I learned was that the person sitting in front of you actually knows more about their problem than anybody. So it's a pretty good idea to listen to them. So in answer to your question, communication is actually the most important thing we do in everyday practice.
Absolutely. And a lot of times you're always busy rushing patients because you have to see a lot of patients in in an outpatient setting, for example, and sometimes you don't stop to really listen to them. So what is the importance of being active listeners, and how can we make patients feel heard and still have a timely session? Because I think that's the challenge between them. Give them the treatment they deserved, listen to them, but we also have to see all the patients that get scheduled in the clinic for us. So I think that's a very difficult challenge.
Well, yes. And so what I would say is, there are some important aspects to effective communication, and you used the word active listening. So, and I think you hit it right on the head. So what is it that makes an active listener? So I'll give you an example here. So if you're in a conversation with somebody, many times what we do, instead of listening to what the person is saying, we're trying to formulate our next thought. So we're not actively listening to what the person is saying. We're trying to think about what we're saying. In order to be an active listener, you actually get the thought out that okay, I'm not going to formulate what I'm thinking right now, but I'm actually going to hear what the person is saying, because hearing and listening are two very different things. You know, my mother-in-law, when she was alive, salt of the earth, and she had these wonderful pearls of wisdom. And one of her pearls of wisdom was, Todd, we have 2 ears and 1 mouth, and that's probably a good ratio.
It's
So,
true.
so I think, you know, it leads right into your question of how do we give patients time without them feeling rushed or as though they're not being listened to. And I think you and a lot of your listeners probably know that when a person is sitting in front of them, the likelihood is, if they've gone through the healthcare system, that they've not really been listened to. And if you can allow that person to know that you are going to listen to them, that's huge. You've got them to buy in. So, so how do you do that? Well, one thing that you can do is you can tell them, look, I am going to ask you a lot of questions. And if at the end you feel there's more information I need to have, I'm going to need you to tell me that. Because generally what happens is, if the person thinks that they've got their obligatory 5 or 7 minutes with you, they're going to want to tell you everything, whether it's going to help you determine what the problem is or not. So I'll give you an example. In terms of trying to make the patient feel heard and still have a timely session, I think one of the most important things we can do as clinicians is to control the evaluation or the examination. And you can preempt that, having the patient tell you a lot of different things by saying, I want to hear your whole story. Let me ask you specific questions, and then at the end, please fill in for me. Because what you've told them right up front is, I am really interested in your story. So controlling the evaluation is very important. So, and I think many of your listeners are going to know this because we've all gone through this. If you ask a question like, well, tell me when this episode started, and then the patient starts to tell you about they had to take their cat to the vet because they have a digestive problem, because their cat ate some gummy bears, and as they were sitting in the vet's waiting room, they met a person that they hadn't seen in 23 years, and then go on for a long story. By the time they've gotten to the crux of the matter, 20 minutes is up, and you haven't gotten the information that you need. So controlling the interview is really important. And one of the skills that you can really work on is gently reconnecting or redirecting the patient. Just bring them back around. That's fantastic. Was there a day that this started? Was it a week? Was it a month? So you can sort of frame your question that way, and that way gently redirect them. The other thing that I would recommend is, sometimes people are just not going to be able to answer your direct question. And if they can't do that, move on. Then you go to the objective part of the examination, because no matter what you do, you're not going to get the patient to come around. So those are a couple of things that you can do to make the patient feel like they're being heard and also have a timely session.
Yeah, I think that's a very important skill, knowing how to gently focus on the answers that you need without cutting off the patient, or they feeling that they were just being rushed to the answer. But
right.
I think that's experience, because we don't learn this. It's just over time, seeing a lot of patients, you start to have to finding your way to focus on what's really important, because you can stay minutes there talking and not getting the answer. So I think that's really hard.
Yeah. Yeah.
And what are the important aspects of effective communication? So we talked about being an active listener. Anything else that you want to mention that's important?
Yes, I think I'm kind of old school, and I'm one of those people who thinks that words are actually important and they mean something. They actually make a difference. So what I would say is just be very careful with the words that you use. Try to stay away from words that have maybe sinister pathologies. And one example, and I know sometimes we use these words like lesion, and so if I'm talking to a patient and I say, well, this is how your lesion is behaving, when you hear the word lesion, what are you thinking? Because I'm thinking something really sinister. Oh, maybe I better get my effects in order.
Yeah.
So I try to stay away from these hot button words like that. I would also recommend that using simple words and words in a language that the patient understands. So I think those are some important things that we can be considering for effective communication. The other thing that we can do, and we talk a lot about this on the diploma program, and that's asking neutral, non-leading questions. So how many times you have a patient in front of you and they generally want to give you the answer they think you want to hear. And many times they want to do this because they want to please you. But that's not going to help you in any way come to a conclusion about what the problem is. And so I'll give you an example there. I want to find out what positions and movements make this person better or worse. And I ask the question, does your back hurt when you bend forward? And I'm shaking my head, yes. And the patient's thinking, oh, so my back is supposed to hurt when I bend forward. And then what do they say to you? Yes. Well, now you've led the patient. They're going to give you the answer they think you want here instead of the truth. When in fact, what you want is the truth. So there's a better way to ask that question. So instead of saying, does your back hurt when you bend forward? What about, when you bend forward, are you better, worse, or no different? That's a neutral question. You've given them a choice. Now, what the patient knows is none of these is correct except for the correct answer. They don't feel obligated to answer in a certain way. But and then there's a problem sometimes. Some patients will say, I never bend forward. I was told never to bend forward. So in my head, I'm thinking, how can you possibly get through your life without ever bending forward? But that's this. And what you want is this. So how do you do that? You have to make it relevant to the patient that's sitting in front of you. So instead of being argumentative or clashing, I might say, oh, well, let me give you an example. Let's say you have to bend forward to brush your teeth, or you're bending over to tie your shoes. Does that make your back better? Does it make it worse? Or does it have no effect? Now you've made it relevant to their lives, because everybody has to put their shoes on. Everybody has to get dressed. Most people, you would hope, brush their teeth. These are bending forward types of exercises, and they're relevant to the person that's sitting in front of you. So now you have three things. You're an active listener because you're not interrupting the patient with what you want to ask. You've chosen your words very carefully in language that the patient can understand, and you've asked them a neutral, non-leading question so you get to the truth. So those are three really effective communication things that you can do to be effective with the person that's sitting in front of you, and make the patient feel like they're not being rushed.
No, that's all awesome examples, because I remember when I did my first McKenzie course in Brazil with José Liberato,
Uh-huh.
and I was just amazed how he talked to the patients. It was so simple, but it was so easy for them to understand and to give the answers. I was like, that's impressive, his communication skills. And I been noticed that that's like a McKenzie thing that's very strong on the method. And
Yes.
I was like, that's so simple. Like the method is simple. Simple. We know that it's not simple, but it's something that's easy to transmit to the patient without putting fear and all of these things. So I think that's amazing how it can be so simple, and how the skilled therapists can be so so smart with their words and their way of communicating. So that really impressed me. And I think that's a general thing that we see in McKenzie.
Right. Well, you bring up a really interesting point here, Mariana, because sometimes people conflate simple with simplistic. And these are two really different things. So if I give somebody one thing to do, and they've come from a lot of different interventions where somebody's given them a list of 10 or 12 exercises, and I say, I'm going to have you do one thing, and they say, but you must be belittling my problem because I've had this for 6 months and you're giving me one thing. It might be a simple thing, but there's a very specific reason for that thing. The complexity is in the thought process that goes into figuring out what that thing is. But to be able to communicate it to the patient in a very concise and simple way, that's the essence of what we want to be doing.
Yes. And I think that for therapists, that's very challenging, because that's now how we learn from our teachers in college. So
Correct.
we are used to use that words to show that we know what we are talking about, but not just that, we just don't know another way of communicating, because that's how we learn, that's how we repeat, that's how we talk to each other.
Right.
So I still, for me, it's still really hard. I try to mimic the words, the way of explaining, cutting the finger, all the models that really help us. Yeah. And you see how simple and easy it is. It's just a matter of practice and having someone that you can mimic, per se, right, the way that the way that they communicate with the patient. So I think that's something that really attract me to the method, and I feel like it's a challenge for most therapists, because that's not how we are trained to talk to the patient.
Well, sometimes just changing your mindset, and you bring up a really good point, because what we learn are these very complicated words, and apparently this imparts some sort of expertise on you. And you use these big words for the patient, and it's frightening for the patient, but you're using these big words that, make you feel good, or you think makes the patient think that you're smart. Who is that for, really? It's not for the patient. It's just not.
Exactly.
Right? So are we there to make ourselves feel clever, or are we there to help the person that's sitting in front of us? And if we're there to help the person sitting in front of us, when we truly know that it's about the person in front of us and not us, it changes the way you communicate with that person, because then you're going to do everything you possibly can to get that person to understand what is important and what they need to be doing to fix their own problem. It's not about us assuaging our egos or making ourselves feel clever.
Absolutely. And I think another good point is the neutral questions, because I feel like sometimes we as therapists, we get anxious to get the answer. So we want to direct the way we want it to go. And we don't even notice sometimes you are asking these questions trying to get a specific answer. And and I feel like when you are secure and you know what you're doing, it's easier to ask the neutral question, because whatever is the answer, you're going to know what to do. But sometimes I feel like we want a derangement. It has to be this way so we can get it right. And I think it's this anxiety of the therapists in the process of learning that make things a little bit more confusing.
Yeah. Well, that's confirmation bias, isn't it? We want things to be what we want them to be, not what they are.
Yeah. Yeah.
And what did Robin McKenzie always say? He said, I'm just looking for the truth. And the patient has that truth. And if we're listening, we're going to hear it. And that's one thing I always tell the diploma residents. The person sitting in front of you will always tell you what their problem is if you're listening. That's one of those absolutes. They might not know the words, but they're always going to tell you what the problem is. Yeah. And generally I would say by the 4th or 5th week of the diploma program, the diploma student will say, did you hear what they said? And I would say the important thing is that you heard what they said. And that's when the light goes on.
Yep. Yeah, it's funny because I was just seeing a patient before our conversation here, and she was saying me her thoracic was burning, and she started walking, rotating to the right side. And she said that she was better. She was walking, literally rotating to the right side. I was like, she's telling me what is the direction.
Exactly right. She's told you what the problem is. She's told you how to fix it. And then you repeat it back to them, and they think you're brilliant.
Yeah.
And in fact, you are, because you've listened to exactly what they've told you.
Yes. Yes. It's crazy. It's exactly like that. And now, what are some specific words that you use with patients, students, and referral sources?
So with patients, I always think back to a fellow named Adrian Lau. He does a lot of his work on the study of pain. And this goes back maybe about 4 years or so. He spoke at a McKenzie conference when you could actually go to one. And he puts a slide up, and it says, what are the 5 most important words in medicine? And so I turned to the person next to me who was faculty member, and I said, you're going to be all right. And she looked at me like, what are you talking about? And he puts this slide up, and it says, you are going to be okay. So in terms of words that we use with patients, that is so powerful, because somebody comes into your office, Mariana, and they've had back pain or sciatica for 5 months. And they've been to people that have said, I've seen your x-ray. This is the worst I've ever seen. I don't know. Once again, I'm that guy who thinks that words are important, and worst actually means something to me. So how many times could you possibly see the worst? And if I hear that, I'm thinking, I got to get my effects in order. Let me get my will in order, because this is the worst. Or you're bone on bone, or I can't believe you're walking. You evaluate somebody and you know their problem is mechanical, that they're going to respond to position and movement. And you tell them with a good amount of certainty, because you've evaluated them, that you're just going to be okay. This is a mechanical problem, which means it's position and movement related. And by the way, I'm a mechanic. So it's a nice mix. I can help you with this. Yeah, and the other thing that's kind of interesting is, we've all had this. If you've gone through the McKenzie system, you generally can teach people how to fix their problem, even if they've been to a lot of other places. So let's say the person sitting in front of you has been to 2 or 3 other interventions, and they've had 6 or 8 weeks of physical therapy or chiropractic or osteopathic, and they've had injections and they're not any better. And you give them an exercise, and within a week or so, they're 75 or 80% better. And then this person gets really angry. How many times have we seen that? Why didn't anybody else tell me this? So now here's your perfect opportunity. You can have a communication with the patient that says, well, they didn't do it because I'm more clever than they are. Or they didn't know how to help you. As if the person that they've seen has done something with ill intent. So what I would say to that is, who is that good for? It's not good for the patient, because even though they're getting a good result, what's happening? They're leaving angry, right? It's like taking poison, and that anger is like taking poison and hoping somebody else gets sick. That's not going to happen. What about a communication like this? Look, these people, they did the very best they could for you. And by the way, all of these other interventions that you've have informed us how to move forward. It's given us extra information. You've spent months and months and months trying to find the right answer. Pat yourself on the back for being so persistent. Look how persistent you were in searching out the correct answer, and you found it. That's a positive communication.
What a nice way. Yeah.
Instead of feeding into that negative, one is to assuage our own ego, one is to help the patient get to where they need to be. So these are some words that I would use with patients. I just stay away from scary words that connote sinister pathologies. The example I used before was lesion. And stay away from the things like, I can't believe you're walking with this. It's the worst I've ever seen, because it's not helpful.
Remove their fear.
Exactly. So those are words that I would use with patients.
And now with the students that I know you have many.
There are so many, but I think one of the most important things, and we can all think back on this because we've all been students, and we've thought of positive interactions we've had with instructors, and we've thought of negative interactions. This is something that comes up all the time in the diploma program. If I've gone through an evaluation with a student and a patient, and then the patient leaves, and the student wants some feedback, and I say to them, okay, fantastic. You asked neutral, non-leading questions. You allowed the patient sufficient time to formulate what they wanted to say to you. This is all terrific. You came to the right conclusion, but when I say the word but, what are you thinking?
Now something bad's going to come.
The hammer is now going to drop. Now something really bad is going to come of this. And I forget everything that was said before. What about this communication? Neutral, non-leading questions, came to the right conclusion. You gave the proper intervention. And if you want to make that more effective, here are a few things that you can add. So just substituting one word, and for but, takes the negative out. And how many times have we heard over the course of our education the term constructive criticism? When you hear that, what are you thinking, Mariana?
I mean, I feeling I'm going to listen something that I have to improve. So something that I did wrong, probably.
Yep. And I'm hearing criticism.
Yeah.
I don't hear constructive anymore. I hear criticism. Here it comes. And there's a simple thing that you can do there. And I would substitute the word feedback for criticism, constructive feedback. So those are a couple of things that I use with students that they're simple words. You get to convey the importance of what you need the student to learn, but you take the negativity out of it.
And do you feel that your results with the students are better when you change the way you are talking to them or using different words? Do you feel like they respond better?
I look to the result, because at the end, they become self-learners and they're self-critical. That's the key. They become introspective. They can teach themselves. And that's the whole idea of the diploma program. To teach people how to be self-critical, not just in evaluating the literature, but in evaluating their own performance and their own communication. When you can stop and say, wait a minute, the way I asked that question was a leading question. Let me stop and ask that in a different way. That's when you know that you've been successful.
Yeah, you are making them stop to think about it, and you don't even have to criticize them. They already are aware of what they are doing.
They are. And just like you want your patients to be self-learners and empower them, no different with students. In each case, you're teaching. The window dressing might be a little bit different, but the principles are exactly the same.
Yeah, absolutely. And now with referral sources.
Oh, this is always, we're walking on hot coals here, right? You don't want to alienate your referral sources. And so what I would recommend, there are hot button words with referral sources too, aren't there? Words like disc, extension, and sometimes even using the word McKenzie can be a hot button word, because people have some preconceived notions about what that is. How many times have your referral sources say to you, do McKenzie exercises? Robin McKenzie never invented an exercise. He developed a system of evaluation and treatment to determine what is the correct intervention and how do I teach this appropriately to the patient to make them independent. It's a reasoned thought process. It's not an exercise. It's not a protocol. And many times we've had this, and I don't have this so much anymore because after 40 years, I have referral sources who actually know and understand what it is that we do. But sometimes you'll get a referral source that'll say, they'll write a prescription on it that give you 7 or 8 different interventions. And they'll say, Williams flexion exercises, no extension, underline, underline, underline. So we're going to flex this person anyway, right? Because everybody gets flexed. We evaluate them. We'll bend them forward. Their symptoms peripheralize. So we know that this is probably not a good thing. And then you ask them to extend, and their symptoms either abolished or centralized. And the patient's looking at you and they're waiting for you to tell them something. So are you going to say to them, well, the doctor told you to do this, but that's wrong. I'm going to tell you to do this. Now you drive a stake through the referral source and the patient. Not a good outcome. Okay, the patient has read the referral that's come from the doctor, and they'll say, what about this, and this? Great. I'm going to talk to the doctor. And between the three of us, we're going to figure out what is the right exercise for you. I would get on the phone to that referral source. And if they're really belligerent, I might say something like, Dr. So-and-so, I saw in your referral that you want Williams flexion exercises. We had your patient flex and bend forward during the examination. They got worse, but we found some exercises that made them feel better. Do you want us to do the exercise that makes your patient worse, or would you like us to do the exercise that makes them feel better? That's a different communication than you're wrong, I'm right. You put the ball in their court, and many times they'll just say, oh, I don't care, do what you want. And now it's not about you, it's about what's doing the right thing for the patient. So that's a way that you can communicate with your referral source.
And don't the doctors get their ego hurt by this description of doing what you ask make the patients worse?
Well, again, you choose your words very carefully. This patient got worse with forward bending, but there are other exercises that we can do that can help them along before we start bending them forward. Would you like us to proceed that way? So you can be flippant, or you can find the right communication with your referral source. But again, you want to be specific with the person that you're talking to.
Yeah. And I think that's a very challenging way to communicate with the doctor, because most of the times they have no idea about what we do. So how you are going to communicate that and make them understand what you're doing. So I think that's really hard.
Yes. And again, it's knowing the person that's sitting in front of you. Comedians call this having a point of view, to be able to connect with the person that's in front of you so that you can find some common ground.
Yes. No, and the patient as well, because the patient wants you to do what the doctor told them to do, because they want to, how about this, and this that you're not doing with me that the doctor asked you to do?
So Robert Metcalf has a wonderful word for this. He calls it a therapeutic alliance. And you can preempt this by saying, I am going to reach out to your doctor because we should all be on the same page. And now the patient knows that you're all pulling in the same direction. You're working together.
Yeah, absolutely. And now we are talking about these specific words that help us with the patients and being able to explain them in a way that they understand. So how can the therapist improve or develop this skill?
Yep. I think the most important thing that we can do is use analogies. You alluded to analogy before, the cut finger, right? This has been used in the McKenzie Method for many, many years. And this is something that the patient can see. And for those who are not familiar with this analogy, if I send somebody home with extension for their low back, and I say, okay, here's why I want you to do what I want you to do. Have you ever cut the back of your knuckle? And then most people have. What happens when you bend it? Well, of course, that cut is going to open up. You might not do this. Wow, my finger's not healing. But if you keep it out straight, it's going to heal a lot faster. No different for your back. Forward bending is like this. Bending backwards, sitting up straight is like this. Now, at some point, you're going to have to bend forward. Otherwise, you have a useless finger, but not yet. First things first, let this heal. then you can start bending forward. So I think analogies that mean something or are relevant to the patient in their everyday lives, very, very important. And that's the simplest thing you can do. So think about things that are important to you and that you do in everyday life. And these are analogies that generally will resonate with the patient.
Yeah. And I think that's a very powerful way of communicating. I remember how many analogies I heard on the first McKenzie cars, pulling the finger, talking about the posture syndrome, and many, many others that we have a group that sometimes we share. People come up with different analogies to help the patients. And then we share like, oh, I used these and it was really good because the patient really understood and helped them in the treatment. So I think they're very powerful.
Yes, I would agree 100%.
And in your experience being a diploma educator, is this something that you approach in the program, that you help the students with this language? And what are some students' weaknesses and difficulties related to this topic?
Yes. So this is something we approach every single day. Why? Because they're with me for 9 weeks, or they're with another diploma tutor for 9 weeks, or 2 diploma tutors, and they're seeing patients. And they're watching how the tutor and then they themselves are interacting with the patient. And then you get to sit back, and unlike being in the clinic where you're just seeing patients all day long, every day for an entire career, you have time to sit back and reflect and see what's important and what's been effective. So they get to try out different analogies. So yes, this is something we approach every day. With regard to weaknesses or difficulties, we see this almost across the board. And again, it takes about 4 weeks before people can really get a handle on this. And that's asking a neutral, unbiased question. And when the student starts to feel that asking that leading question is like dragging your fingers across a chalkboard, then that behavior starts to change. It is really difficult to change a habit, Mariana. So if you're working for years and you're used to asking the question this way, what do psychologists tell us? About 1,000 repetitions of something to make it a habit. That's 30 times a day for 30 days. That's 6 weeks of work, 30 times a day. So 9 weeks is about a good amount of time to see a change.
Yeah, it becomes automatic. We don't even notice when you're asking the questions because we're used to ask them. So it's really hard.
Yep. So I would say there, every question on that evaluation form has a specific intent. You should ask it with that specific intent. Don't ask a question just to ask it.
No, absolutely. And I think that the McKenzie, it's a lot about communication and being intentional. So I think that the method really makes us a better communicators if you know how to use it. And I think that's the common ground that I see between all these amazing instructors that we have. We start noticing how they talk to the patients, how they approach, because we see them on the courses treating patients. So I think that's essential for a successful treatment.
And this is years of experimenting and repeating and to see what works and what doesn't. And we spend the first part of the diploma program is spent on how to ask a question and how to listen.
It's crazy how basic and how important it is at the same time.
You know, a lot of people come in and they think they're going to do the diploma program and they're going to learn how to do a specific technique, or they're going to get a secret decoder ring with secret words. And really what we teach them is how to listen and how to ask a question.
It's crazy.
It is a little crazy. Yeah.
So let's transition to our final questions. What is your favorite resource of information? Any books or papers that you like in particular?
Well, of course, I think that the lumbar spine, the cervical spine, the extremities, the blue books, invaluable. With regard to resource for patient, the treat your own series of books, because it takes all of this information and it gives it to the patient in a way that's palatable and understandable. That being said, there are 4 studies that I go back to all the time. And on the diploma program, we cover hundreds of studies, because by the time people get here, they are really facile with the literature. And so what I would say is, we're not treating the literature. We're treating the person that's sitting in front of us, but we can use that literature to guide our decision making. But there are some studies that I think are really, really important and that I use as reference all the time. One is the XPOS study, and I think a lot of your listeners will be familiar with that. And it's really a study looking at the prevalence of extremity pain of spinal source, and that it's Richard Rosedale is the lead investigator there. So I use that frequently, and patients are very interested to know why, if they have pain in their elbow, am I looking at their neck first? There are 2 studies that are much older, and these are Audrey Long studies. One on specificity of exercise, which is now about 18 years old, and then a follow-up study on the prognostic value of directional preference and centralization exercise. So I use those studies quite frequently. And then the last study that I use is the Savonin study, where they looked at knee surgery versus sham knee surgery in treatment for meniscal tear. So the study, came out in 2013. I think it was December of 2013 in the New England Journal of Medicine. And it's just one of those wonderful sentinel studies where they randomized 100 people to 2 groups, 50 with confirmed meniscal tear on MRI, and they were going to get a surgery, and then 50 with confirmed meniscal tear on MRI were going to get a sham surgery. And it turns out after a year, there was no difference in the 2 groups. One group got exercise, one group got surgery. So these are studies that I refer to very frequently.
Awesome. And we have a lot of good studies
Yes.
to look. So there are some good tips. And what would be the best advice you give to the clinicians that are starting their careers?
That the key is to find a good mentor. So you learn what you need to learn to pass a licensing exam when you go to physical therapy school. You learn how to be a clinician in the clinic. And a way to do this is to have a good role model. Find yourself a really good mentor. And the way I see it is, it's like an apprenticeship. And it takes a long time, and you can save yourself a lot of trouble and a lot of time by finding the right mentor. Absolutely. So that's what I would recommend for the clinician just starting out. And it's interesting, because if you don't have that, what happens is you end up going through your day and your year just doing what you've always done. And I've spoken to a lot of young therapists who say, I'm burned out. Now, I've been doing this for 40 years, and I see something really interesting every day. So the whole notion of I'm burned out, what I say to that is, how could you possibly be burned out if you were never on fire? Find something that makes you on fire. It's not the profession's job to do that for you. That's your job to seek that out.
That's a very good point, because I think it's something that's very common in the physical therapy world. We hear a lot about burnout, and it's a very good point. You have to keep looking. As you said, you were about to give up, but you keep looking until you hopefully find something that fits with your way, your vision, your style. So
Yeah, I don't know. After 40 years, I come to work at 7 o'clock in the morning and I leave at about 8 o'clock at night. And patients say to me, you do this for 40, how do you do this for 40 years? I say, do what? I talk to interesting, nice people all day long. I get to help them solve their problems, and then somebody pays me for that. And it's generally the person sitting right in front of me that pays me for that. That's a nice gig. So I think maybe aside from rock and roll star, or Major League Baseball player, I don't know that I'd rather be doing anything else.
that's awesome. Yeah. And what personal qualities or abilities that you think are important to be a successful physical therapist?
So I think this feeds right into the entire topic. And those qualities would be a good listening skills, good communication skills. And I think a big part of that is trying to figure out what the patient's motivation is to perform what you need them to do. So you're going to look for a therapeutic alliance. Some people actually want to be told what to do. And I know some physical therapists who they bark at the person in front of them and say, you have to do this, you have to do that. And then others see a different motivation. But it's interesting because I'm not big on barking at people and telling them what to do. Leading them to the right answer, I think, is always more effective, but not always. I've had patients who they don't do what I've asked them to do. And then I'll say something like, well, look, I'm not big on telling you what to do, but what is it that I can do to help you do what you need to do? And they'll say, I need you to tell me what to do. And once again, they've told us exactly what they need. And then I'll tell them, okay, you must do this exercise 10 times every 2 waking hours. And if you don't do this, you're going to be in trouble. And this is what some people respond to. That's what I would recommend.
And then you're going to need some years and experience to feel which patient needs, because everybody's different. So
everybody is different, but that's the beauty of this, right?
Yeah.
It's like raising children. They will tell you exactly what you need to know if you're paying attention to them.
Yeah.
It's like the patient that you talked about before. Oh, when I rotate this to the right, that feels better. They've told you exactly what they need. And the person in front of you will always do that.
Yeah. You just have to pay attention.
You got to be paying attention.
Yes.
You got to be mindful. You have to be intentional.
Yes. I think that's the message.
Yeah.
Well, Todd, that's been awesome. A lot of good tips and words and ways to communicate. I think it was very, very helpful. And if our listeners want to learn more about you or contact you, is there a way that they can reach you?
There is. So I would recommend, we have a website, montclairphysicaltherapy.com. There's another one, calltodd.com, and that's patients generally will use that. And I do have an email, T.Edelson, my name, at montclairphysicaltherapy.com. And I think your website is so darn long, it can't possibly get to anybody else. So I think your listeners will find me that way. Or you can find me through the McKenzie Institute.
Awesome. Todd, I appreciate so much you taking the time to share your expertise, your experience in communicating with patients, with referral sources, with students. So I think it was very, very helpful. And I think all our listeners are going to really enjoy this interview.
Well, thank you so much for having me on. I appreciate your time as well. And you should keep doing what you're doing because it's really a wonderful service for people.
Thank you.